Hi, I'm Ed Wong, and this is a session on the imaging of intracranial infections. Thanks for staying here to the end of what's probably been, what is a fairly long day. Image here, this is a Ixodes damidis tick, which transmits the spirochete responsible for Lyme disease, but also a nice slide to get people's attention. Neuroimaging has really given us a way to see a lot of entities that people just used to fear in the past, as manifested by different means in the popular media. But even still, despite what we can see insofar as complications or the effects of these diseases, we tend not to be as specific as some of the serologic or other testing parameters which the clinicians may have. So what I'm hoping to do today is just go over some of these diseases, present a more image-heavy type of presentation so that we can all relax and hopefully confer some additional information as well. What we'll go ahead and start off with is a pyogenic infection. What we've got here is an illustration of some Staphylococcus bacteria sitting on skin, nice grape-like clusters we all remember from microbiology. First thing we'll talk about is meningitis. And remember, when we think of the causative organisms, we'll be thinking of strep pneumo, we'll be thinking of meningococcus, we'll be thinking of listeria. In younger patients, we'll be thinking of Haemophilus influenzae, although that has been significantly decreased due to vaccination. And the real role of imaging here is to identify the complications of meningitis as opposed to truly be sensitive for it. There's a significant rate of false negatives, even with contrast-enhanced MR imaging, such that recent research has sort of focused on additional modalities, see what we can do to just go ahead and up or increase our sensitivity to the presence of meningeal disease. And what people have found most recently is that some of the modalities that can help us are post-contrast flare imaging and also post-contrast fat saturation T1 weighted images can sometimes increase our sensitivity. But even with these modalities, you may still have some false negatives. Right. So the main thing is going to be looking for the hydrocephalus, the abscess formation, the infarcts, the cerebritis, mass effect, and ventriculitis associated with these lesions. So let's take a look at some examples. Here's an example of a patient who had CSF documented meningitis. And what we see in the post-contrast imaging is really not that much, but what there was some slight increase in leptomeningeal enhancement in some of these posterior cerebral sulci. What we see on the T2 weighted imaging is also not too much, but what we do see is some signal abnormality seen within the left basal ganglia here. This was non-enhancing and was felt to represent some degree of infarct resulting from vasculitis involving perforator vessels due to basal meningitis. A little more conspicuous example here, the post-contrast imaging on the left demonstrating increased leptomeningeal enhancement seen posteriorly, also in the basal frontal lobes, and also some thickening of enhancement along the dural margin at the tentorial margin with some increased enhancement at several cerebellar sulci. What we see on the flare imaging is that the flare imaging really brings out the signal abnormalities in all of these regions, and that we see it here posteriorly to a greater degree of what we're seeing here in the post-contrast, routine post-contrast imaging. Another yet more conspicuous example, and what we see is, again, the flare imaging and the post-contrast imaging demonstrating the abnormal enhancement within multiple cerebral sulci. But here we've also got abnormal signals seen around the right lateral ventricular trigone and some abnormal signal along the ependymoma, compatible with ongoing ventriculitis. And in the same patient with meningitis, we've got some ventricular enlargement as manifested by increased width of the third ventricle and the lateral ventricles compatible with an associated hydrocephalus. One thing to remember is that while the flare imaging can increase our sensitivity to the presence of signal abnormality for meningeal disease, whenever we have larger collections of CSF, such as within the third ventricle, the flare imaging is going to be prone to flow artifacts here, and this should not be misinterpreted as the presence of infectious disease in these cases. Just as a reminder that not all leptomeningeal disease is going to be infectious in nature, this is a patient with fiducial markers along the scalp for a planned resection. This patient had leptomeningeal disease resulting from metastatic breast carcinoma, other neoplasms, metastatic neoplasms, primary glial neoplasms, lymphoma can produce disappearance. And it's also to remember that in the setting of leptomeningeal disease, another possibility is something like sarcoid, where you have granulomatous inflammatory disease resulting in this kind of meningeal enhancement. Here's an example of a complication of meningitis, abnormal signal seen at the left basal insula and just at the junction with the midbrain, and we see some associated restricted diffusion compatible with infarct owing to arteritis. Here's an example of another complication. What we see on the pre and the post-contrast T1 weighted imaging is an area of mass effect and poor distinction of gray-white interface at the left frontal lobe. There's extensive enhancement seen in both extraaxial spaces as well as within the parenchyma here on the post-contrast imaging with some minimal rightward midline shift. We've got some prominent associated restricted diffusion seen here, and what this turned out to be was not even just a simple case of cerebritis, but what this turned out to be was a venous infarct owing to thrombosis of a frontal cortical vein. Here's another example of a different type of complication. What we have here on the post-contrast fat saturation imaging on the left is the presence of proptosis with increased extension anteriorly of the globe. We've got increased enhancement of orbital fat, and we've got increased thickness of the ipsilateral cavernous sinus. What we have on the image on the right is within the expected region of the superior ophthalmic vein. What we have here is abnormal hypointensity compatible with thrombosis. This was a case of cavernous sinus and superior ophthalmic vein thrombosis. Here's another case of complication related to meningitis. On the post-contrast imaging on the right, what we see is abnormal enhancement seen in relation to sulci, right here extending posteriorly. And what we also have is some faint enhancement lining the ependema. This is seen in association with signal abnormality, and the FLAIR imaging is compatible with a ventriculitis in this patient. The next thing we'll talk about is an epidural abscess. Now, as opposed to meningitis, this is typically going to be due to direct extension from an external source, whether it's something like a sinus infection, mastoiditis, following an operation, projectile injury, something like this. In many cases, the dura will prevent parenchymal involvement due to its strength, but the things to look for in these cases are evidence of the source of infection and to go ahead and to look for that associated cerebritis. So in this case, T2 weighted imaging demonstrating extraaxial collections with a convexity not too dissimilar that from what we would expect from something like an epidural hematoma. In addition, there's associated parenchymal signal abnormality involving the anterior frontal lobe on the left. And what we see, which becomes more conspicuous on the post-contrast imaging, is that there's a number of rim-enhancing collections seen in the extraaxial space, in addition to abnormal faint enhancement of the parenchyma. What we also see is within the frontal calvarium in the expected region of the frontal sinuses is abnormal enhancement too. And you can almost imagine a small focus of osseous dehiscence here, and could the infection have spread from this sinusitis that this patient has? Here's an example of diffusion-weighted imaging in the same patient demonstrating restricted diffusion within the content of the sinus, not too dissimilar from what we might see in a parenchymal abscess, as we'll get to later. Here's another example of direct extension of disease to cause a cerebritis. On the FLAIR imaging and T2 weighted imaging, what we have is extensive signal abnormality and mass effect involving the right frontal lobe. What becomes less apparent is that there's some slight extraaxial collections that we can see here in the T2 weighted imaging. When we take a look at the post-contrast imaging and we use our multiplanar reformatting capability to look at the images further, what we notice is that there's also abnormal enhancement within the calvarium, and that this was a patient who had a craniotomy, and what ended up happening was that there was infected craniotomy segment with direct extension of disease to cause a cerebritis in this patient. So let's go ahead and talk about cerebral abscesses. Now, traditionally, we're going to be talking about rim-enhancing parenchymal lesions, and some of the differentials that we'll have for something like this would include things like a cystic metastasis or an aggressive glioma like a glioblastoma multiforme. Some of the additional hints that we can use to try to further differentiate a cerebral abscess from these neoplastic lesions include the presence of thinning along the ventricular aspect, looking for a daughter lesion, something that almost looks like a little bud of the lesion, and the presence of a hypointense T2 rim. But are there additional MR modalities that we can use to further help us out? Well, we can take a look at diffusion-weighted imaging, and what we'll expect to see is restricted diffusion within the content. Now, conceptually, it would seem as though an abscess contains a lot of purulent material. It's thick and it's kind of cheesy necrotic stuff, and so that's why you have restricted diffusion. Well, some investigators looked at this issue and found that really the thing that correlated most with the restricted diffusion of abscess content was the presence of increased density of inflammatory cells. And the point of this is to say that in a patient who has a cerebral abscess who's getting treated, you may have restricted diffusion that goes beyond the time frame of the patient's actual infection because of the presence of inflammatory cells there. We can also use MR spectroscopy, taking a look for lactate and amino acid peaks seen on the lower end of the ppm spectrum, and we'll see an example of this. So here's an example of an older woman. She was a sort of a party socialite type of person who ended up having some focal neurologic symptoms and headaches, and she was referred to our institution for a malignant glioma. And looking at this initial imaging, you can imagine why. There's a rim-enhancing lesion seen here at the left frontal lobe. Some of the other things we were thinking of were a tumor-affected myelinating lesion or even an abscess, but the surgeon was convinced that there was no way this could be an abscess. Why would a person like this have something like that? 5 days later, we have progression of the lesion, extension of edema, and here's sort of an example of what we talk about as being sort of a daughter lesion to these abscesses. And still, it was thought of our surgical service that potentially this was a highly, highly aggressive glioma, and that this is still something that needed to come out. When we take a look at our diffusion-weighted imaging, we've got prominent restricted diffusion within the content, and when they went to the OR, this basically was a large collection of pus. Some work done by Granol in 99, basically taking a look at MR spectra documented in brain tumors as well as multiple abscesses. While all of these lesions demonstrated lactate, as demonstrated by this reverse doublet on the echo time of 136 milliseconds, only the abscesses also had this amino acid peak near the 1.0 or 0.9 point per ppm range. And when they went ahead and looked at these lesions, none of the brain tumors had elevation of or presence of amino acid peak, while all of the abscesses did. So this is one potential way we can use additional MR modalities to help us out. Even in cases where you have sort of smaller abscesses, as in this patient who had multiple abscesses due to embolic phenomena from endocarditis, you will have some of these lesions also demonstrating some restricted diffusion, as seen here in the diffusion and ADC imaging. Just an example of some cerebral abscesses mimicking cystic metastases. Next thing we'll talk about is tuberculous infection. CNS infection is usually due to secondary hematogenous spread in the setting of primary disease elsewhere, and small cortical foci of infection form. These then rupture, resulting in a distribution of meningoencephalitis. Vasculitis and hydrocephalus are common, and the distribution of these lesions tends to be more basal than we typically see with a routine bacterial meningitis. In addition, the amount of enhancement that we see can sometimes seem more diffuse and even pachymeningeal. Tuberculomas are parenchymal lesions which may not even demonstrate enhancement in the early phase, and we'll see some examples of this. So here's an example of tuberculous meningitis, and on a flare-weighted imaging on the left, what we see is abnormal signal within the suprasellar cistern and the left middle cerebral artery cistern. This is seen in accompaniment with abnormal enhancement on the post-contrast imaging. This is the same patient, and what we see higher up is not only some mild ventricular dilatation compatible with a slight hydrocephalus, but we also see areas of enhancement involving the basal ganglia on the left, compatible with an associated extension of disease to form encephalitis, likely along the perforating vessels. Here's a more prominent case, and what we see here is extensive enhancement within multiple cerebral sulci. We have moderate enlargement of the ventricles compatible with the hydrocephalus, and we see a predominantly cortically located focus of lobulated enhancement with its associated edema, all findings that we can see with the tuberculous meningoencephalitis. Here are some additional images demonstrating the basal predilection for meningeal disease related to tuberculosis. We see abnormal enhancement basically filling these cisterns, and we see also coating of the trigeminal nerves here. We see extensive abnormal enhancement along multiple foci, both the cerebrum and cerebellum. Here's an example of some tuberculomas from a friend of mine who's a practicing Indian neuroradiologist. And what we see here are pre-post contrast CT imaging, and for all the world, these look very similar to solid metastases. Here's another lesion that we see at the left frontoparietal region. On the pre-contrast, not seeing too much. On the post-contrast, also demonstrating enhancement, and again, looking very similar to a metastatic focus. Next thing we'll talk about is spirochetal infection, and again we have our image of the deer tick here. And Lyme disease is the most common vector-borne illness in the U.S. If you do get a tick bite, just get the ticks removed as soon as possible. because it typically takes about 2 to 3 days for the bacteria to actually get into your system. The geography is going to be in heavily wooded areas, so in the northeast, but also in the northwest as well. While many patients will have sort of vague, non-specific findings of sort of a malaise or lethargy, some of the CNS findings we'll expect to see are findings of a meningitis, cranial nerve palsy, or even a peripheral radiculitis. And so on imaging, some of the things that we'll be looking for is the presence of meningeal enhancement, as we've seen earlier in other cases of meningitis, but also enhancement along the cranial nerves. And in cases of more chronic disease, what we can sometimes see are the presence of small punctate white matter T2 signal abnormalities, and we'll see some examples of this. So here's an example of a patient with documented Lyme disease, and on the post-contrast fat saturation imaging, what we see is prominent enhancement along the trigeminal nerves bilaterally. On the coronal imaging, we can see this to nice effect on the pre- and post-contrast imaging with the trigeminal nerve seen here and the nice enhancement seen on the post-contrast imaging. This is a patient who had been evaluated for by their neurologist for chronic fatigue syndrome, fibromyalgia, sort of issues of chronic pain. And what we noticed on this patient was that there was a small white matter lesion. As you can imagine, this is somewhat nonspecific. We might have said this was mild microvascular disease. We could have even said this was a small focus of demyelination, almost just sort of an unidentified bright object. It's sort of a case of something which is more profuse with multiple punctate lesions identified throughout the white matter. And this was a patient who had initially presented with the typical rash or erythema migrans of Lyme disease. And so this was a patient known to their neurologist as having chronic Lyme disease. Next thing we'll talk about is viral infection, and specifically to focus on herpes meningoencephalitis. So distribution of this is typically going to involve the mesial temporal lobes, the basal temporal lobes, often with putamenal sparing, but other areas of basal brain can be affected. This is a fairly aggressive and can be an hemorrhagic encephalitis, and so the clinicians can even find blood in their tap and think that they've done a traumatic tap. But the key thing about this is that early treatment is crucial, and you can increase the survival rate from a 75% death rate for non-treated patients to almost 90% with early treatment with appropriate antibiotics such as Zovirax. And one thing to mention is that in cases where we can miss disease on routine MR imaging, that diffusion-weighted imaging can be more sensitive. So a couple examples of this: a fairly florid case of disease with extensive signal abnormality and enhancement involving the near entirety of the right temporal lobe, but also involving basal aspects of the right frontal lobe as well. We've got some patchy enhancement here in the post-contrast imaging. Here's a less prominent case, but still well visualized, what we see on the pre-contrast imaging: some mass effect and hypointensity. On the post-contrast imaging, vague and irregular enhancement in this region, and prominent flare signal abnormality. So one thing you might ask is, how do we tell this from a temporal lobe glioma or some malignancy of this sort? And actually, that's what it was thought that this patient had. They had been referred to our neurosurgical service. They underwent WADA testing and because this patient had repeated seizures. And upon pathologic review, following a partial temporal lobectomy, this was found to be herpes. Slightly more subtle case, we see diffuse signal abnormality within the mesial right temporal lobe, another case of herpes. Here's another more florid case of herpes meningoencephalitis, and here we've got extensive signal abnormality with the associated diffusion restriction in multiple areas bilaterally, including insular cortex on the left, and our more usual distribution involving mesial and anterior temporal lobe, and also portions of the basifrontal region on the right. Finally, here's another lesion. Again, some vague enhancement here at the mesial right temporal lobe, associated with slight mass effect and some signal abnormality on the right. So again, how do we know this isn't going to be something like a temporal lobe glioma? Sometimes one thing that can help out is spectroscopy. And here, if we take a look at the voxel on the left, this is the normal side, what we can see is that there's a sort of normal relationship of NAA demonstrating neuronal integrity, choline demonstrating membrane turnover, and creatine establishing our baseline in an arrangement that we're typically used to seeing. When we take a look at the area of signal abnormality, we see there's significant elevation of choline relative to what we saw previously, and there's extensive neuronal loss. These findings are compatible with tumor, and that's what this turned out to be upon stereotactic biopsy. That being said, it is important to realize that these techniques can be somewhat difficult in the area of the basal brain, where the skull base can cause a lot of magnetic field inhomogeneities. Another type of viral infection that we need to remember is HIV infection. HIV dementia, or AIDS-related dementia, is an AIDS-defining illness. And the current theory of what's going on is that you've got chronically infected immune cells or microglia in the region, which are just constantly secreting neurotoxins. The dementia doesn't typically happen until the late stage of an infection and is a diagnosis of exclusion. On an imaging basis, what we're expecting to see is a nonspecific periventricular white matter signal abnormality. This is going to be patchy in the beginning, and it's going to seem more confluent later in time. So here's an example of this. We could see this in moderately severe or severe microvascular disease, maybe in some cases a demyelinating disease, perhaps not as diffuse, but we see this patchy, very ill-defined white matter signal abnormality, predominantly around the margins of the ventricles. One differential of this is going to be progressive multifocal leukoencephalopathy, or PML. It's not only going to be seen in AIDS patients, but other immunocompromised patients, for example, some transplant patients on immunosuppressant therapy. These patients will also undergo progressive deterioration, but in contrast to the patients who have AIDS-related dementia, will more often have findings of focal neurologic symptoms. This represents a reactivation of a latent viral infection within neural structures that the patient already has. And what we see in imaging is typically the absence of contrast enhancement and some mass effect within focal white matter signal abnormalities, which extend to spare gray matter. And interestingly, more recently, with the advent of highly active antiretroviral therapies, some cases have demonstrated improvement in the degrees of signal abnormalities with these patients. So here's an example of PML with some fairly extensive white matter signal abnormality, predominantly involving the left frontal lobe, but extending from this periventricular region all the way to the convexity. And there's some mildly expansile appearance to this, but there's certainly some sparing of the gray matter that we can see well here. The same patient on FLAIR imaging, just demonstrating an additional lesion involving the right frontal lobe, but again, this mass effect and extension to spare the gray matter. Here's another case of a patient. This was a transplant patient, but with several foci of signal abnormality involving the brain stem, as well as white matter, again extending to the convexity. And here, more clearly than in the last case, you can see that there's some focal mass effect that's associated with this, but again, that we're pretty much sparing the gray matter here. And some post-contrast imaging nicely demonstrating that the majority of these lesions are non-enhancing. Again, the same lesion here, some mass effect, again with sparing of the gray matter. Creutzfeldt-Jakob disease is not really a viral disease, but a prion disease whereby an abnormal protein goes over and converts other proteins to assume an abnormal configuration, so that it ends up reproducing itself within the body. This ends up causing a vacuolating or spongiform encephalopathy, and these patients go into sort of an inexorable mental decline and progressive dementia. This is the same, a variant of this, variant CJD, is going to be the disease that's related to the bovine spongiform encephalopathy and mad cow disease that caused quite a bit of anxiety, especially in the United Kingdom a few years ago. Things that can help out are some more specific findings on EEG and looking for this 1433 protein, which has been helpful in diagnosing these cases. In addition, there have been cases where the diffusion-weighted abnormality, and we'll see some cases in a second, have been helpful in early disease because they were the earliest abnormalities detected on MRI. So here's a case of an elderly gentleman who became progressively demented. The question was, is this going to be something like multi-infarct dementia? Is it going to be Alzheimer's? It's fairly difficult to detect much in the way of abnormality here on the pre-contrast T1 weighted imaging. Perhaps some increase in hypointensity associated with the corpus trium bilaterally. Maybe some vague enhancement here on the post-contrast, but nothing clear. On the FLAIR imaging, it becomes more apparent that there's extensive signal abnormality, not only involving portions of basal ganglia bilaterally, but also the insular and frontal cortex, right greater than left. And here on the diffusion-weighted imaging, we see the restricted diffusion in association with these regions as well. Here's another image from the patient's diffusion-weighted imaging, again demonstrating nice increased signal and the restriction on the ADC images. Here's an example of another patient who ended up having CJD, professional artists who started to sort of lose their skills, and basically some fairly prominent basal ganglia signal abnormality, leniform caudate nucleus signal abnormality, some vague signal within the thalami bilaterally, but also signal abnormalities involving portions of cortex. And on the diffusion-weighted imaging, it becomes fairly clear where the abnormalities are. But again, in some cases, these may precede the T2 signal abnormalities that we see with these lesions. West Nile virus encephalitis is something that's gotten more press recently, something fairly common along the West Nile, but in the Mideast. But more recently, in 1999, there was a large outbreak in New York State. But since then, really, the disease has spread throughout the rest of the country. Most patients who get the disease will be asymptomatic. They might experience flu-like illness, but patients who are younger or older may end up with more severe encephalitis, and this can be a fatal illness for them. And so as far as imaging findings, a lot of the findings will be nonspecific, for example, a meningeal enhancement, but sometimes, in some cases, with a more diffuse encephalitis type picture, what we may see is symmetric corona radiata and deep gray involvement. Again, sensitivity of MRI may be low, but diffusion-weighted imaging may be helpful, and it's uncertain if that could represent some form of early immune cell migration to these lesions. But here's an example of West Nile encephalitis that we've had in our institution, and we've got a fairly interesting pattern of central gray matter signal abnormalities extending up to the corona radiata, some involvement in the brainstem, red nuclei as well, and the diffusion-weighted imaging giving us a fairly distinctive type of appearance here with the restricted diffusion into red nuclei and the thalami bilaterally. But again, sometimes these centralized sort of signal abnormalities in a patient with a diffuse encephalitis type picture, consider a flaviviral or viral encephalitis such as this sort. Fungal infections, cryptococcal infection is going to be the most common fungal infection to involve the CNS. And basically, this is a type of yeast, but this affects people with decreased cell-mediated immunity, so patients with AIDS among other patients. But the imaging findings that we'll expect to see, again, some patients will have a cryptococcal meningitis, and remember when we all learned about looking at India ink staining for cryptococcus and things like that, but there are better serology tests for that. You can have parenchymal lesions, which do not look very different from tuberculomas, and we can also see gelatinous pseudocysts, which can be fairly specific for this. And what we'll see are cystic lesions, which typically do not enhance and are not associated with a prominent amount of associated parenchymal edema. So here is just an example of a cryptococcal meningitis, and again, demonstrating that our contrast-enhanced FLAIR imaging is going to be perhaps the most sensitive for this, demonstrating some abnormal signal within right-sided posterior sulci, perhaps some increase in leptomeningeal enhancement seen on the post-contrast T1-weighted imaging. Again, same patient, again demonstrating the signal abnormality seen on the FLAIR imaging, probably the most conspicuous out of the three sequences here. Here, this is from the literature, but demonstrating probably the most prominent case of gelatinous pseudocysts that's been documented. But basically, what you notice with each of these lesions is that it's a cystic type lesion. A lot of these will be centralized along the courses of the perivascular spaces, but what we won't see is much in the way of any associated parenchymal edema, and these lesions, again, should not enhance. Cysticercosis is a parasitic infection caused by ingestion of tapeworm eggs, and the thing to remember about this is that a lot of times when these lesions initially present, they sort of live in coexistence with in harmony with the brain for several years, and it's really when the degeneration and inflammatory response occurs that the symptoms, the focal neurologic symptoms occur. There are parenchymal, intraventricular, and subarachnoid forms, and one thing to look for is visualization of a little scolex within these cystic lesions, and that can be almost pathognomonic. You may not see it in every case, but when you do see it, you really should consider cysticercosis strongly. Albendazole is the treatment of choice, but there's several lesions, including ocular and spinal lesions, which are usually not elected to be treated medically because if there was treatment in degeneration, it would end up causing more symptoms. So, when we look at the life cycle, we expect to see the lesions in pork. We ingest them and get tapeworms. We contaminate the soil, and somehow pigs get to that again, and the cycle begins anew. but whether due to auto-contamination or poor hygiene, sometimes the cycle sort of bypassed, and instead of getting encysted lesions in pork, we end up with encysted lesions in people. And CNS involvement is quite common. So here's some examples here is some images of the cerebellum in one patient with neurocysticercosis with extensive cystic lesions identified within the cerebellum. The same patient higher up at the convexities, and what we see are cystic lesions. There's not much in the way of edema around these lesions. You might argue, is there a small scolex or an area which does not look cystic here that might make us think about neurocysticercosis? Here's imaging from the same patient, and here in the sagittal we see multiple parenchymal lesions within the cerebrum and cerebellum, but there's also small foci of enhancement here within the subarachnoid space. Here's another case. We had the benefit of following up this patient. So this is a patient who had multiple lesions, you can see here, and most of these are sort of fine. They're sort of in a static state, but he had one lesion here in the right frontal region, which was more enhancing and representing ongoing degeneration or inflammation of this lesion. So this patient got put on albendazole to treat for this, and what ended up happening was that there was more edema and more mass effect related to this same lesion as the inflammatory response and immune response became more pronounced. And as time went on and we went on to follow this lesion, this initial lesion went ahead and started to contract. And, this is something that we would expect to eventually become a parenchymal calcification. But then other lesions started to enhance and start to degenerate and give this patient symptoms. Here's a sort of an interesting appearance of the subarachnoid variant of disease, or racemose neurocysticercosis. And you end up with sort of a multiloculated appearance of the extraaxial spaces. You can see here the Sylvian fissure looking sort of bizarrely dilated in this multilobulated form. In this patient, in the same patient, we see on the T2 weighted imaging the same appearance with splaying of the flow voids in the middle cerebral artery. But again, one thing that's interesting with these subarachnoid lesions is that we actually won't see the scolex in these lesions for whatever reason. When we went back and went to this patient's neuroimaging, because they came to our institution several times, we noticed that just a little bit beforehand, there was some asymmetric distension of that right Sylvian fissure. And when we went even further back, when the patient first came to us, there was a small lesion seen here at the Sylvian fissure. And so the question was this something that eventually developed into this? Here's another example of a cystic lesion with a scolex in it, a nice associated inflammatory edema, and no restricted diffusion. And this is sort of what we expect at the end stage, multiple parenchymal calcifications. Here we have gradient echo MRI to bring out the susceptibility artifact of a focal parenchymal calcification. And here's an example of a patient who had neurocysticercosis and ended up being shunt dependent because of multiple parenchymal and subarachnoid lesions and persistent distension of subarachnoid spaces, which ended up giving her hydrocephalus and shunt dependency. And here's an example of another ring-enhancing lesion, tiny little scolex we can see here. Toxoplasmosis is going to be a reactivation type of disease in immunocompromised patients. It's going to be the most common cause of cerebral lesions in patients with AIDS, and often empiric therapy is often initiated. These are going to be ring-enhancing lesions. The distribution of these lesions is often going to be basal to involve the brainstem as well as basal ganglia, but can be seen more peripherally. Here's an example of more peripheral toxoplasma lesions, somewhat difficult to distinguish from cerebral abscesses here. Here's some additional lesions seen here along the right frontoparietal junction. Prominent amount of edema associated with these. Could this also be some irregular cystic metastasis? And here's an example of sort of more what we might see as far as the distribution of these lesions here within the midbrain and also seen in the periventricular distribution. One of the big differentials in AIDS patients as to ring-enhancing or regularly enhancing lesions within the central brain is going to be CNS lymphoma. And so one of the things is how do we go ahead and evaluate this? Some people have used thallium SPECT, some people use FDG PET. Another way to go about doing this is to go ahead and use MR perfusion and to use the increased vascularity of the neoplastic disease to help us sort out what's going to be lymphoma. As we can see here, manifests as the increased increased color on the color map, and then toxoplasmosis, which is almost like a form of abscess, and here we've got decrement and devascularity associated with this lesion. Just some other illnesses. Amebic infection is going to be something that's pretty rare. The story is typically one of a young child who's been bathing on a freshwater lake and ends up with a meningoencephalitis type picture. These are almost uniformly fatal, and unfortunately we just have non-specific findings of meningitis and cerebral edema. This was a case that was proved on autopsy to be amebic infection of the brain. And basically just scattered areas of abnormal enhancement within brain parenchyma. Echinococcal infection is going to be another type of parasitic infection that we see, typically more endemic in places where sheep and cattle are raised, but internationally we see these in places like Greece, places like Turkey, and what we'll see is large multiloculated cystic lesions. Some of these lesions can be more solid, but you may again, the cycle is somewhat similar to what you have with neurocysticercosis, where we end up as an unintended host of the organism. Basically, the cycle goes between lambs and the carnivores which eat them, but we end up getting the lesions and very rarely in the brain, as opposed to the hepatic lesions, which some of the body imagers are used to seeing. And you may see something like this, so an extensively large multiloculated cystic lesion of the brain without much in the way of associated solid soft tissue. And when they remove these lesions, getting something like a bucket of cysts, with the surgeons being careful not to rupture these, given the risk of associated anaphylaxis with these lesions. Going to the other end of infections, we have torch infections. The incidence of these are decreasing due to vaccination and due to mandatory screening of neonates and pregnant women. In the U.S., the most common torch neonatal infection is going to be CMV infection, and what we're going to see is intracranial calcifications and periventricular signal abnormalities. The thing to remember with torch infection is just like any other neonatal insult to the developing brain, you can have associated congenital abnormalities, and so that's one thing to look for extra in these patients. So here's an example of CMV with diffuse scattered calcifications in the periventricular distribution. There's prominent volume loss with associated prominence of the ventricular system, but there's also abnormalities of cortical development with a relative lesencephaly associated with the infectious disease. Here's another case of a patient who had calcifications along the periventricular region on the left, but associated with this, in this patient, is a cleft compatible with schizencephaly, also another congenital developmental disorder associated with infectious disease on occasion. And here's another patient. Does this patient have something like a mineralizing angiopathy? Do they have a disorder of calcium metabolism? In this patient, it turned out to be a long-standing history of CMV infection. And finally, to finish up, just to talk very briefly about ADEM, or acute disseminated encephalomyelitis. It's not really an infectious disease, but falls under the purview of diseases that we may see in patients in the setting of recent infection. So typically, this occurs 1 to 2 weeks following viral illness or vaccination. And unlike some demyelinating diseases, we can see gray matter as well as white matter involvement. And it's hard to distinguish on an imaging basis sometimes from other demyelinating disease, especially multiple sclerosis. And so sometimes we'll need to take a look at this clinical history. And so here's an example of ADEM in one patient where we've got some very faint enhancement identified within white matter here along the left corona radiata, also seen in a periventricular distribution, seen more posteriorly. When we take a look at the flare-weighted imaging, we see a number of white matter signal abnormalities. In another patient, this could easily be multiple sclerosis, but in this patient, it turned out to be acute disseminated encephalomyelitis. So as a summary, while we may not always be identifying the causative organism infection, things we can do are to use flare-weighted imaging, diffusion-weighted imaging to increase our sensitivity. Advanced MR modalities such as MR spectroscopy or MR perfusion can be helpful to sometimes further assess these diseases. And one thing to harp on is to go ahead and contact your clinicians when you have any suspicion of herpes encephalitis. It is a treatable disease, and early diagnosis is key to patient survival.